Afternoon, colleagues, and evening for those who are as far as India. My name is Sandile Mahlangu, today we are together for this session. We are hoping we will all learn. May I welcome everyone for today's session. We are hoping to learn more from each other. You are free to share your views and understanding. And also you are free to ask any question or any concern lonayo, whether it's a presentation or it's a case presentation. You will be free to do that. If ever you have joined together as a team in one gadget, may I request that you also introduce yourselves by listing your names and your facility, where you are coming from on chat. And then with me here, I have three members. I have Mr. Pungwayo, who also acts as an ICT person at Hospice in this forum, in this program. He's our palliative care nurse from Lubombo, and we also have our clinical manager, our sister, Mages Bongile. And then in today's session, it's a follow-up, or it's a completing session for our pain management series. Actually, colleagues, we are about to finish our series around November. So after November, then we will have our test and then get our certificates for attending this series on pain management. So today we'll be looking around on arthritis, but maybe before we go further, may I request that you introduce ourselves so we can be able to know if we hear one another. So may I start with Mr. P. Dlamini. May you introduce yourself, sir?
Afternoon, colleagues. My name is Pennington Dlamini. I'm a palliative care nurse who's working in the Eswatini region under Eswatini Hospice at home.
Thank you, Mr. Dlamini. Zamo, long time. Yes, Nurse Zamo, you can introduce yourself. Okay, Zamo is a little bit busy there. Tandazile, can you introduce yourself, Pat? I hope you are getting us Tandazile that side. Okay, Zamo, can you introduce yourself? Okay, Zinhle and the team, can you introduce yourself, guys? Do they hear us? Hello, Zinhle. If they don't hear us.
Hi, team. My name is Zin. I'm with Nancy Ronduli, palliative care nurses from American Hospital.
Okay, you are welcome. We were already worried. We thought you don't hear us. I don't know if Tandazile will be able to introduce yourself too. I know last time you were able to introduce yourself only on chat. I don't know if today you will be able to do that. Yes, Zamo, are you ready to introduce yourself? I think she will be back. And the last time Tandazile couldn't introduce herself. but we are hoping she can hear us. So today, last time we were looking at adjuvants or analgesic adjuvants in palliative care. The session was presented by RFM Hospital, and the presentation was presented by RFM team. It was a wonderful presentation. Actually, what we learned there is that on top of the pain medications or the analgesics that we have, we can also add the adjuvants, which can help us to manage the pain effectively. And that was the last session to cover up maybe the principles on pain management. So today we are looking around on management of arthritis. Then we will have Mr. P, who will then present on the case for today. Maybe without the waste of time, colleagues, may I present on the didactic presentation for today, which is arthritis, pain management. So may I just present on that? I hope everyone can see the slide. So what we are going to do today, we'll be looking at arthritis pain management in palliative care. We know that this is one of the common problems that we face as palliative care clinicians or providers in our different areas. So what we are going to look at today is that we will understand the pathophysiology of rheumatoid arthritis and osteoarthritis. We'll also review the signs and symptoms of both arthritis. And then we will also look at how these conditions affect a person's everyday life. And then we'll understand how to manage this arthritis pain, looking at the previous keys that we have been using, we have been learning previous presentations on pain management. So we'll now be specifically looking or applying them towards arthritis pain. So in general, arthritis is about joint inflammation. So this is one of the common problems that our patients go through. So it's all about joint inflammation, so inflammation of the joints. As long as your body has a joint, then there can be inflammation there. And one of the things that we need to understand, there are many myths that are there. And arthritis can affect babies and children, can affect even adult people. Though it is common to be known to be adult condition, but also children, they undergo that. Actually, every person during his lifetime, he can be diagnosed with either arthritis. So there are many types of arthritis that are outside there. So there's one that is called osteoarthritis, which has to do with the cartilage there. We also have the rheumatoid, which has to do with the synovials. We also have childhood arthritis, juvenile arthritis. They also what we call gout. We also have systemic lupus, when the body is attacking itself. Then we have also erythematous. So these are different types of arthritis, but the most common ones can be osteoarthritis and rheumatoid arthritis. And osteoarthritis is the most common arthritis that we face, or most of our patients are diagnosed with. And then these are the common myths that we usually have in our facilities, and those also who are at home. Most assumption is that arthritis is just a condition, is not a serious condition, and this myth has resulted to most patients not manage using the principles of palliative care once they are diagnosed with arthritis. So you find that simple, will just give them calcium and nothing else will do. Yet arthritis itself, it's a serious condition. So, and then also we have this myth that arthritis affects all the adults in such a way that even when we are in our prime times, we find that we don't even take to notice it and take serious when we have bone-related issues. We don't think of arthritis, we think of other issues. And then arthritis is a normal part of aging. You know, this is one of the rationale. Once an elderly patient comes and presents in our facilities, and we will then say to the older person, it's because you are growing old. So it's part of being old that you have to suffer through this bone pain. So, and then the first thing we say is because of your age. So we normalize it as part of being as a normal process of being old. We also have this myth that arthritis is not much can be done for those living with arthritis. So we feel like there's nothing much we can do, such that it is easier to overlook these people who present with arthritis when they come to us, because we feel like actually there's nothing we can do with this arthritis. So we end up not doing anything. And then sometimes when it comes to prescribing non-pharmacological, especially body physical therapies, when it has to do with exercise, we feel like they cannot do any exercise. Like she can be or he can be bedbound. So these are the myths that rotate around arthritis, especially with these patients of palliative care. These myths may result to reluctance to refer or mismanagement at some point. So let's look around the bone. I will not dwell that much in this, but let's look around the anatomy of a joint, as arthra is for joint inflammation. So we look at the normal joints. So the first picture, this one, is about the normal joint. So when you look at these joints, you see that one of the things that you need to understand when it comes to arthritis is that the first sign that you will be, or you are already suffering arthritis, is when you are going through joint pain. It is not normal to suffer joint pain. So once you are beginning to have recurrent joint pain from nowhere, that could be a sign that you are going through arthritis. So in a bone, we have what we call the articular, we hyaline cartilage. If you like Makaya chicken, and you like the drumstick, you know, that hyaline cartilage in a chicken, it's very nice to bite. So that's the hyaline cartilage, this area. So it's like a covering between the two joints. So even the other one from the taper or the leg, it's also having its own. And then it allows the friction-free movement. So it's like a very soft area. Once it has this synovial fluid, then it means it's jelly-like, so it's easier to walk without any problems. And then the other one area, this blue one, also here. So this other picture shows the abnormal one, with abnormal, especially with there's no cartilage very well here, and there's also this inflamed synovial membrane. So these are the membranes. So these membranes, they are responsible to carry the synovial fluid, and then they ensure that every time they release the synovial fluid, so it lubricates the hyaline cartilage, so there's no friction there. So the cartilage is kept healthy and well nourished. So it creates that cushion between the bones. If a kaigi waba involved you can tell when they are cutting the joints. You see the synovial fluid spilling off. So that's what we call it. So in a normal human being, you have to have this working very well. So once there's an abnormality like in this bone, once the cartilage is finished, then we have osteoarthritis. Once this synovial fluid is finished or is inflamed, then you have a problem of synovial. You have the rheumatoid arthritis. So when you look at these two arthritis, like I said, the common one is osteoarthritis, but we'll need to compare both. So the osteoarthritis is most common form of arthritis. So what happens here, it's a degenerative disease. What happened, the cartilage degenerate, and then the bones, they come together because now there's no cartilage in between. So when the cartilage wears down over time, patient may experience a painful bone-to-bone articulation. So when you are walking, you begin feeling pain because you are walking. And it starts slowly, but at the end, then you find that then now you feel it's more severe. And then the related factors that could lead to osteoarthritis may relate to age, as we normally say, because you are old. But family history, if you have a history of this issue, you find that it will come. Sometimes joint injury, especially people who are athletics or sports-related activities or other injuries. But most of these people, they are the people who are sport fanatics, or we call them sport fanatics or athletics. They usually go through this. Also, having excessive weight, then would lead to osteoarthritis. This is the most common one. And then also rheumatoid, this one is a chronic immune disease characterized by the inflammation of the synovial joint. So as I showed that there's this synovial area, so then once there's this inflammation due to immune system and has a bilateral effect on the joint. How do you tell that this person has osteoarthritis? It's just that when the joints that are painful is on the right, you will find that also the left side of the bone. So symmetrically, both left and right, you will find that the pain. Yet in the other osteo, if it can be just one knee, because that's the one that has been affected. But in this one, if it's the knee, also the other knee will have, then you can anticipate that the one is synovial, is rheumatoid arthritis. And it results in joint deformity and immobilization. You find that people will never be able to walk, and it can aggravate the severity of osteoarthritis and can come to many factors, because sometimes it comes with immune-related issues. So the symptoms. So on the left side of the screen, you have the rheumatoid one. So you see, the person ends up having disfigured. Sometimes they will even go small and small. So you end up having disfigured extremities, especially the tarsals and the digitalis, they end up disfigured. So the clinical symptoms, you can see morning stiffness lasting more than half an hour in the morning. In the morning, you cannot walk for 30 minutes. You cannot move your legs. Simultaneous symmetrical joint swelling. Once you see someone having swelling legs or knees or ankles or wrist or even the digital joints, so you can tell now that this is possible rheumatoid arthritis. So you see the inflammation coming in. And this one is not relieved by rest. Even you tell that go to rest, it is not going to be relieved because it has nothing to do with activity. And then the person will experience a fever, sometimes weight loss. And then when they are experiencing the weight loss, you will discover that they end up having these swollen legs. You can vividly see the legs very swollen, even erythemas. And then they will experience fatigue and then anemia, because once something has to do with immune, some will end up having lupus-related issues, and then they will end up having lymph node enlargement, and some end up having nodules. Nodules, they have like bumps. So you see them like that. So that picture there is showing those people with rheumatoid arthritis, especially at advanced stage. And then osteoarthritis, joint pain. So it can be just one leg. So also there you'll find that in the morning you will have those stiff joints, and then you will experience sometimes severe joint pain, and my joints will sometimes lock. You cannot move very well. So joints will be cracking. When your joints are making sound, yeah, some will say that's a sign you are old. And that's a sign you are coming closer to arthritis too. So sometimes there will be joint swelling, but the trick with this joint swelling is that it's not symmetrical. it's where there's a problem only. But once it becomes symmetrical, then you can query rheumatoid. And then sometimes the loss of joint flexibility or strength, these people cannot stand on their legs, they cannot stand because there's nothing to help them stand. The joint is not working because the cartilage is not there. Then you can say double coco because it's most common when you see them, but everyone can have that. So when we are looking at the general management of arthritis, the major goal in arthritis management, you see that is to relieve pain and inflammation and prevent further damage. That's the major goal when we're managing it. So we are trying to relieve the pain. We are also trying to relieve inflammation, and we're also preventing further damage. So these are the three things we're normally looking around. And this comes together with anxiety. So when an elderly person or any person present with arthritis, also consider that they are going through anxiety and depression. It's not easy to see yourself being paralyzed, yet you have been able to do things for yourself. So they go through anxiety, they go through depression sometimes, who will help me? Who will do this? They lose themselves. They feel like, I was interested in soccer before, but now because of this, I cannot do this. And hedonia takes over. And the whole day, because of self-care deficit, they'll end up becoming in low mood. So, and then they end up becoming helpless. So that comes to spirituality. They feel helpless. They feel like, it's finished with me. I cannot do anything. Think of those people who end up even look small. Like you see, they go down, they lose weight. The person was 50 kg, was 60 kg, but now is 40 something kg. So they feel helpless. They lose self-image. They end up lack of self-control. They feel like I cannot control myself anymore. Like I cannot take charge. I cannot do things for myself. They end up with low self-esteem. They feel like self-image, and then they have lost who they are. So because now they are dependent, some will they have to use crutches. Think of a 15-year-old, a 30-year-old person now has to be dependent on supportive devices. So they don't feel good. And this one is most common with the people of rheumatoid arthritis. So management of arthritis should be comprehensive and requires a comprehensive assessment. We've done that in our previous presentation, that we have to do comprehensive assessment, look at the PQRSTF, looking in terms of all the sides of a human being, like these common problems are there. Management of arthritis pain requires both pharmacological and non-pharmacological management interventions. So we need to pull those two because now we know the goal is to relieve pain, inflammation, and further damage. Some you find that they will be taken to certain surgeries and then they will take some time and have no pain. But then we look at the pharmacological management of rheumatoid arthritis. There are 4 types of medications used to treat rheumatoid arthritis. We use NSAIDs that usually we provide NSAIDs for the inflammation. We will also use corticosteroids like prednisolone and dexamethasone, which are sometimes called the adjuvants, as the RFM presented last time. We also use disease-related anti-rheumatic drugs like methotrexate, which is a gold standard. And this also is used under oncology. I don't know if Tandazile have ever used this drug because it's also used under oncology. So also they use it as a disease-modifying drug to help with this rheumatoid arthritis. So for severe pain, also we consider using opioids to manage that pain, which also is prescribed together with laxatives. And then we also have alternative medication for rheumatoid, which can be olive oil, leaf extracts. Like last time, our nutritionist taught us how to use traditional herbs and diet in terms of pain management. So we can use this to manage it. So ginger root extracts, omega-3 tea, aloe vera, and then olive extracts. And then we need to be cautious of omega-3 because it interferes with blood clotting drugs. So you might find that then it will lead to bleeding. So we also need to understand that if you combine with NSAIDs, then you might have a problem. So also those alternative medicines will help. And these ones you can source them from local pharmacies if they are there. And then also non-pharmacological interventions, as you can say. The first one is the exercise. Let's encourage these people to engage in exercise, especially people who are overweight. So because being overweight strains the joints and leads to further inflammation. So we can even prevent this ourselves, engage on physical exercises, control our body weight as possible as we can. So we can prevent ourselves from osteoarthritis too. Doing the following exercise at least 4 times in a week for 30 minutes. So you encourage the patient to at least do these activities. One of it, 4 times a week for 30 minutes. May take a walk, light jogging, water aerobics, cycling, like yoga. You can do stretching depending on what the patient is feeling or is able to do. You can encourage them to do that so that it can help them. And then also you can use dietary formulas. We can have supplements like folic acid, vitamins, and calcium, magnesium, which are sometimes the deficiencies that support the bones. So we can also use that one. So those mineral deficiencies, they also lead to rheumatoid arthritis. So we can encourage them to take a supplement. And also other underlying conditions must be considered because you will find that when a patient is on dialysis, some supplements will not be feasible to be used. So you need to also consider those things. And then surgical intervention, they can do that. They can do synovectomy just to deal with the synovial area, so increase the function of the joint. It decreases pain and inflammation, and beneficial as an early treatment option. So it's not gonna kill, but it's gonna help in that area just to treat the pain. Remember, the goal is to relieve pain, inflammation. So we need to also deal with that one. So we can also have supportive devices like bracelets and cast splints. So they can also help, they support the injured joint and weak muscles, and then improve joint mobility and stability, and help to alleviate pain, swelling, muscle spasm, and may prevent further damage and deformity. And it's very important to also engage those people from the physiotherapist side in terms of advice on which devices can work best for that person, because it helps. So that's why in palliative care we need an interdisciplinary team. For this person, you will need a physiotherapist to also assist us, as we need orthopedic people. And then non-pharmacological management of osteoarthritis pain may include physical exercise, as we say. We can look at physical therapies and psychosocial spiritual care support, which so under physical therapies, there is a little bit of the same. Exercise, encourage those people to exercise, encourage them to engage on weight loss, encourage them to health and cold therapies. Remember those physical therapies we talk about. So on that joint, you can apply heat and cold therapy. That one is heat, not heat. So depending on the need of the patient, some will need cold, some will need cold. Then activity pacing, also maintaining proper joint alignment. So we'll have different devices to joint. Some will use bandages to wrap around. Some will use certain stockings, so different devices to align that knee, because we know that joint may be already there. It doesn't have cartilage. And also we look around using assistive devices, depending, like those ones I've showed on the screen, to help them ambulate. And then we teach them to ambulate, to practice relaxation, because there's a lot of anxieties if you have these problems. And then physio-psycho-spiritual care. So we look at psychosocial spiritual care. We consider management of anxiety and depression. And you can also, if this is a complicated depression and anxiety, collaborating with the psychiatric hospital or psychiatrist, it is very important. And also engaging social workers as early as possible and helping the people to express their anxieties. We can also use what we call support groups, which we call survivors, so they can help deal with these issues for these people. You know, when you have arthritis and you see another one surviving it, going through, so getting those people who can share their experiences will deal with anxiety and depression. Addressing spiritual distress. This one is also very important because they end up losing hope. Some will not even able to go to church. Some were good church members, but because of arthritis, they are not able to do activities. So they will have anger. They will blame God. Why God has let this find me? So we'll have many things. Some will lose their self-esteem. They cannot connect with themselves. They cannot connect with their God. Existential issues. You know, some people cannot believe in existence. Is that God living itself? So they will to doubt even themselves. Why are they living? So also we need to deal with sexuality. You know, some people will lose sexuality. When you talk of sexuality, the way you see yourself, the way you feel loved, the way you feel sexy to other people. So they still need to be loved. You are so cute, you are beautiful. They need to be told those things. So we need to also engage them. We know that when you are losing your skeletal frame, even your flesh will lose shape. So, you know, you need to continually tell them. Seeing your legs inflamed, your ankles inflamed, you so but now your ankles are so solid, you end up losing that. And also pharmacological management, they also is the same, go acetaminophen, NSAIDs, opioids, corticosteroids. So topical analgesia here will also work. You will wrap it around the painful joint. So you can use those interventions to manage osteoarthritis. But remember that when you're applying them, follow the WHO ladder principle of pain management. It will also help. So surgical, you can do osteotomy, like that gray picture. Here is osteodensis, this one. So osteotomy, you are cutting the bone and putting another element. And then this one is osteoplasty. So they go and remove that finished cartilage. They put artificial one, like this one. So this one is most common. But in the country, I doubt to do this. I've heard people who have gone to European countries or maybe in South Africa to do these procedures, because you'll find that maybe in the country we don't have. So they will go to just that. But I'm hoping it is done. I'm not well versed in terms of inpatient management, but I'm hoping that this one. So they will come and then you'll find that they are living, but they are using these artificial joints. And then to summarize maybe on this arthritis, what I can say is that we need to remember that major goal is to relieve pain, inflammation, and prevent further damage. So that's why sometimes surgical interventions will be applied. So let the patient be reviewed by the surgeons, especially those people from who specialize on bones. And then also let's be strong on pain management, especially total pain management. And then in the symptom management, we need to be very competent in that one, especially the symptom of the sign of inflammation. So how best we can do this? We can also follow the principles of choosing the right pain medication and management plan. Can contribute to effective and efficient management of pain. So sometimes we are not effective enough to manage arthritis because we are not able to choose the right pain management plan to follow that. So there's this protocol we can follow in order to effectively and efficiently manage arthritis pain or any other pain. We have been doing this little bit by bit in our previous presentations. So we need to have complete pain assessment. We have to match the drugs that are appropriate for that pain. So we need to. So if you remember, we once learned about how to match the drug and intervention to the pain type. So we need to know the somatic, visceral, and neuropathic pain. So you need to match that drug with the pain type. consider potential risk, and mostly around arthritis, we have somatic and neuropathic pain together. So we have those two, but we need to assess which one is present by the time you're assessing your patient. Consider potential risk and side effects of every drug and intervention prescribed. You know, some of these patients will end up having comorbidities, so you need to consider the side effects of every drug. Don't take a patient who doesn't have kidney failure, and then you push that patient until he has CKD. So that one is very bad. So we need to always evaluate the benefits. And normally, the major goal here is to pain control. Assess the safest route and mode of delivery of the drug and intervention of choice. So whether you are saying the patient must walk, you need to see, is it the safest activity that you're saying the patient must do? If the patient has risk of falls and then you prescribe jogging, I don't think it is a good intervention. If the patient is unable to swallow and then you give them tablets, you know, so you need to assess those things. Consider who administer the medication, especially with those people who are cognitively impaired. If you are giving an elderly patient 10 types of medications and you expect the patient to take those medications, actually you are just playing a joke. I think there's something you need to add more to help that patient adhere correctly to that medication. Sometimes patients, they abuse the medication because we are not able to assess how are they going to take it and who's going to take it and the way it is going to be stored. How skilled does this person understand it? If that's not the case, then we'll end up mismanaging arthritis again. Determine whether the patient can find and afford the medication or treatment. So sometimes if I'm a referring facility like our mother facilities in the country, like the referring health centers and the regional hospitals, if you are prescribing any drug, kindly find out, is it available in Mkuzweni clinic? I'm making an example. Or is it there at Moti clinic? Because prescribing a drug the patient will not have access to will lead to default and failure to treat management of pain. And you will eventually see this patient coming as ED patients coming for readmission. So it's not good. Emergency, we don't want that. And continuously admission of palliative care patients who have opted to be cared at home. It's not good to see them readmitted for pain management. So we need to find out how are they going to access this drug. Is it available where they are going? How can they access? That's when issues of coming linking with hospice and other clinics comes in when we are discharging those patients or when we are choosing that medication. And also the social, cultural, spiritual context of that pain. Some patients will think that they have arthritis because they will think they have arthritis because some will feel like they will have many concerns around this. So their adherence to the treatment therapy that we are agreeing with them is dependent on the spiritual and social context of their pain. That's what I can share with you, team, in terms of arthritis management. Otherwise, we can manage arthritis pain effectively and efficiently. The myth that is not manageable is not true. We can do manage, but when we work together as a team, together with the patient and making our patient the center, understanding that in arthritis, the goal, whatever intervention we are putting is to alleviate pain, inflammation, and then also to deal with further damage. We don't want the patient to progress with the damage. That's why sometimes we require further investigation in terms of scanning to see how much damage is the cartilage, or if it's the synovial, how much is the synovial membrane damaged. So you can tell that then what would be the appropriate interventions. We are not saying patient must be taken to theater for nothing. Let's evaluate everything. Is it going to be feasible for this patient? And in that way, we can manage their pain. And other things, maybe colleagues, you can add. Thank you so much. I think that's what I can share concerning arthritis. I don't know if we want to add something, team colleagues, to help one another in terms of managing this one. And what I want to point out is that it's a little bit common. At hospice, we have many of these patients presenting other ailments with arthritis. Some as diagnosis, main diagnosis of arthritis, especially osteoarthritis, and we have many who present with arthritis as a comorbid. You will find that he has diabetes mellitus, has hypertension, and then have arthritis. You will find that they have a certain type of cancer, they have diabetes mellitus, they have hypertension, they have arthritis. So it is already there. So you will find that it is there. So it's the most common problem that we are facing. And once the patient has comorbidities that contradict NSAIDs and other bone-related pain medication, it becomes a very challenging to manage them. I don't know if we have made such patient. And sometimes if it's a comorbidity to their pain, we end up losing or under-assessing it, yet it's another trouble that they put. Thank you, Tim. I don't know if you can want to add something. If anyone wants to add, we can add colleagues, or anyone wants to ask, we can share. Otherwise, we're looking at how can we deal with arthritis pain. Yes, Zamo. You can unmute and share. You can unmute and share, Zamo.
Good afternoon, team.
Yes, team.
I'm sorry, I'm not Zamo, but I'm connected to Zamo Keleza laptop. I'm the newcomer, CPN Matenja from the Cancer Control Unit.
Yeah, welcome, thank you.
Yes, bro. So I just want to appreciate your presentation. It was nice and informative. Sandile, I so much appreciate. But please, Sandile, if maybe we can share so that we can, when I have a time, I'll go maybe just restart and read it in deeply. So that's all I wanted to say.
Okay. Thank you, Matsenjwa. I think Zamo will help you. Also, you can also give me your contacts through Zamo. So I will share with you the registration link to Matsenjwa, so you can have a 24/7 access to our database where we upload the presentation and everything that we have done in every session. And also, we will also have this video online just by 4 p.m. today. It will be already running as a premiere, but then it will always be there in our YouTube channel for you to use to review and go back again. But our presentation will be uploaded into our iEco platform. You can access it there once we've uploaded it anytime you want. So I think Zamo will help you, Matsenjwa, to do that. Anyone else, team, who wants to add something on arthritis management before maybe we can give an opportunity to Mr. Dlamini to share case presentation for us today? Yes, Mage Gamenze. You can unmute yourself, direct.
Okay. Good afternoon, team. Thank you for the enlightening presentation, Sandile. Just one thing that I learned while I had a client who developed arthritis due to an accident per the doctor's diagnosis. And he had to undergo knee replacement because his knees were totally affected. And then they said, after giving him, controlling his pain for a long time, they decided no, it was time for knee replacement. But again, they said it was for a while. Say after 10 years, if he's still given life, this patient would need another replacement. So what I'm sharing is, I think as much as we like sports and we do these things, we need to be conscious about the other effects, the accidents, and how these things can progress to complications such as what we're talking about today, because as we are saying, the cost of palliative care is quite high, even the replacement of the joints, the correction of any bone in the body, quite costly. So we need to teach people as well on the prevention wherever and whenever it's possible. This is a very enlightening session, and we see ourselves, we like you were saying, you used to say old people is arthritis, we are associated with age, but even with sports, we need to be conscious on how we deal with this and how the effects can come out to be in future. Thank you so much.
Thank you, Kamet. Actually, as you are saying now, I'm reminded of one of lessons we used to get from college. I don't know what was it. They were saying that as nurses, because today here we are, most of us are nurses, we need to take care of ourselves. Most of us, we end up suffering back pain because we were so generously lifting the patients. We were so generously lifting heavy things. I'm not saying us nurses only, looking at how people are doing outside, how we take care of even our spines, we end up having arthritis in our time. So we need to take care of one another and we need to educate even the caregivers, especially those who are caring for the patients. You will find that a patient has been cared for by this caregiver for 15 to 20 years. In hospice, with people who have provided caregiving to their loved ones more than 15 years, they will end up experiencing arthritis because of how they maneuver in terms of taking care of these patients. So if in your facility you have occupational therapist, use those people effectively, even in terms of capacity building, even in terms of helping the patients take care of their loved ones. Thank you so much. I don't know if I'm leaving someone behind. I want us to now put in Mr. Dlamini for a case presentation. Is there anyone I'm leaving behind who wants to share something in terms of arthritis pain management? And from my committee's sharing is that let's also go deeper in terms of education, in terms of prevention, in terms of management, teach them. Education in terms of prevention, education them in terms of management, education in terms of self-care. Everybody, we know sometimes they can take it lightly, but it's very terrible. Let alone they need to become comorbidities, becomes challenging. You find that I'm not mentioning when now we have kidney problem, it was because kidney have a lot of restrictions in terms of drugs that are needed by the bones. Okay, maybe if you still have an input, may I request that you will put it via chat. I will continually emphasize that this session will be available on YouTube after this presentation by 4 p.m. It will be already running. And also the presentation will be available in our iEco platform immediately after the session. Will be uploading it there. So don't worry that much, you will access it as long as you are registered. If you are not registered, please contact me. I will put my WhatsApp number on chat. May I give Mr. Dlamini this opportunity to share your presentation for today, sir? Thank you, Ngozi. You can go ahead, Ngozi.
Good afternoon, Tim. As I've introduced myself, my name is Pennington Dlamini. I'm a palliative care nurse in the Eswatini region under Eswatini Hospice at home. Our client here is a 61-year-old male who had CVA 2 years ago. The main problem or concern is that is at high risk of having another episode of CVA due to unresolved family issues. And the chief complaint is that the client complained about that he is unable to access his care from the second wife. Actually, what happened here, something went wrong between this client and his second wife, such that he believes the CVA originated from there. In fact, he discovered that the last born from the second wife is not his. So this patient is always thinking about this 24 hours and is unable to sleep. Okay, the assessment. Physically, the client is having left-sided hemiplegia with limited self-care, and he is stable otherwise. Psychologically, he is worried about his care. Socially, he is living with first wife and children. They are raising chicken for sale at the homestead. The elder son is supporting them financially. The client retired on medical grounds in 2021 after suffering a stroke. Spiritually, the client is a Christian and he prays twice a day, morning and evening, and it is helping him to cope quite a lot. The pain assessment, the duration of pain is 2 years, in fact, since the stroke occurred. Description, it is aching, and the numerical scale of pain is on scale 5, and it is a constant pain. It is being precipitated by movement, but is being relieved during a resting. The pain affects his sleep, and also it affects his mobility. The effects of current medication, it's complete actually. The evaluation of pain form and intensity. This was an assessment that was done on 12 July 2023. The pain is on the left arm and leg, and the scale is 5. The intensity is moderate. Duration is 2 years. Possible cause is a contraction on the site that was affected by the stroke. The treatment is on paracodeine 1 gram 3 times a day. The patient is relieved from pain after taking the medication, of which that is fine. It's what we expect actually. Medical history, patient did not have any other chronic illness except hypertension. There is no history of previous surgery. Relevant past medications was paracetamol 1 gram 3 times a day, but the current medication is Lasix 40 milligrams daily, enalapril 20 milligrams daily, nifedipine 30 milligrams daily, and paracodeine 1 gram 3 times a day. The client has retired. He was a security guard, and his level of education went as far as secondary school. Socio-economic class is our class. The marital status is married. Is not drinking, no smoking. The relevant health conditions that his mother had CVA. The advanced directives. DNI orders, there is none. Living will, no living will. Advanced decision to refuse treatment, no. Healthcare proxy, Yes, it's the first wife. Concerns or comments. The client is mentally stable. The vital signs, I was not able, I did not take the temperature here, but the blood pressure was 144/91, pulse 86, respirations 20. The pain score is 5. ECOG functionality score is 2. Okay. The pain scale, the pain score is supposed to be 5. I think it's a mistake. It's supposed to be 5. Or according to this table, yes, it's 2 since it is moderate. Dyspnea, there's no dyspnea. Anxiety 1, agitation 0, depression 1, drowsiness and fatigue 0, nausea 0, anorexia 0, constipation 0, dry mouth 0, poor mobility is 3. Okay. Further plan for this patient, a family meeting to discuss other means of getting money for medication. Since the main problem is that he wants to sell some of the cake from the second wife, whom he was not able to do so in order to assist in buying medication. So a family meeting was not able to solve the problem such that it went up to the traditional court. Actually, one of the reasons that it was not finalized at the traditional court was that some of the family members were acting differently. So there is a need for another family meeting to discuss other means of getting money for the medication, and also to engage a social worker to talk to the patient to find a possible solution pertaining the care. I think that will include getting the family again to pursue the issue at the traditional courts. That's the end of the case.
Thank you, Mr. Dlamini. Maybe you can show the colleagues your main problem. You can scroll maybe up so they can see the main problem. Thank you so much, colleagues. Maybe Mr. Dlamini, while he's still showing us the problem, this is our palliative care patient who was referred to a home-based palliative care for stroke. And Mr. Dlamini has said that his ECOG 2 means most of the time he's bedridden or is sitting down, not doing anything. And his problem or concern concerning this issue that he wants us to help him to resolve is the issue that he is scared that this patient is at high risk of having another stroke, and due to the unresolved psychosocial issues, which includes the family issues rotating around his main assets, which is basically main revenue, the Tingo Modake. And he discovered that the last born also is not his wife. So these are the two issues that are frustrating this man. I don't know what advice can we give this man, because now the concern is that he's constantly rotating around the issues of his cake, and he has tried to explore some legal issues he could. And what can we advise him so that he cannot get second stroke, because the other side is already experiencing contractures? What can we say? How can we help Mr. Dlamini to take care of this patient? Is there anything we can say to him? What most he can do? Okay, Mr. Dlamini, you can turn off your sharing. What can we say, colleagues? What advice can we give Mr. Dlamini? Thank you, boss. Yes, yes, Sizamo. I can see your hand up.
Yeah, it's Cyprian again.
Okay, welcome, Cyprian.
I think for me, this client need counseling. Since I was I used to do counseling, things that you cannot change. You need to accept it. I heard this client has been to the court to talk about the cases, but they don't come to the final solution. For me, this client needs counseling, proper counseling, ongoing counseling, so that the patient can be able to live with this condition.
Thank you.
Thank you.
Yes, thank you. So I hope Mr. Dlamini of Good Cyprian is requesting that maybe you look around issues of counseling. Is it possible for the client to get counseling, Nkosi?
Yes, it is possible.
Yeah, maybe even if possible, we can get local social workers from the DPM's office who can also go deeper in those dynamics in case you will not be there, because one time this man will commit suicide very soon. Because it's like he's persistent on the issue and thinking about it every day is gonna be maybe engaging also those people can help in terms of continual counseling. I don't know yes, Lomunya ngata ngathini. I see the hand from my comment.
Thank you, Tim. Thank you, Ngosi, for his presentation. It sounds tough, especially when it is Babe. Maybe my bit of contribution would be, please take more of your time and explain to him about your fears. I heard that you at the beginning saying he's likely to get another stroke. Maybe if we also approach it from that perspective, make him understand the possibilities and the complications that could be coming up with this. Maybe the Lenhlitio could let go of some of the things that he's holding on and appreciate life instead of Lama letting go and other things, because he still have life. Without or with these things, he could live a quality life with this situation and maybe improve as well than for him to get another CBA. Thank you.
Thank you, Nguni. I hope Ngozi, you got that.
Thank you very much, Mr. Mahlang and Mrs. Kamet. I think that is true, and also the first speaker, that he really needs the counseling to accept the condition as it is, because actually he does not come out clear as to why is the wife refusing with the care, of which maybe during a counseling session we can dig more and get some more information as to where does the problem lies. So I think this one, it's a very good way of approaching this problem. Thank you.
Thank you, Ngozi. I don't know anyone who wants to add for this patient. So far, I've got that maybe to help the patient realign his life goals or health pain management goals for this pain learner. So maybe helping the patient realign, maybe we can achieve, and also looking at real counseling. Yes, and this is a man, maybe even counseling the family, because we don't know who is his side and what are they saying. Maybe they are motivating him to be more frustrated again and again. So maybe even also including the family, and even also engaging the younger wife who's holding the resources to get also the answer. They can also be counseled, to understand what is he going through. Maybe also they can understand that holding the carefully for him not to get the medication he wants to get, what consequences may he go through? Maybe also that one will help in our counseling, that we also include the family members, because he's like a big man. Yes, I'm supposed to Cyprian. Yes, you can share, Cyprian.
Thank you, Tim. I suggest another thing is to find something that will distract the client, not to think too much. Anything that you can do to make to fundraise, to make some resources that can detach the client to not to think too much about the cattle, but to make something that will make him live. Maybe a small business, a small market, anything that can make the client have some resources. Thank you, Tim. That can help.
Thank you, Mr. C. I hope, Mr. Dlamini, you are also getting that one from Cyprian.
Thank you very much, Cyprian. Yes, the client is raising some chicken at home for sale. So I think that is one of the things that he is doing to generate money. So I also agree with you there.
All right. Okay, thank you so much. I don't know if anyone wants to add or comment or ask anything concerning the case while we are moving closer to close our session for today. Is there anyone who wants to add something? Okay, in the absence of anyone who wants to add, thank you so much, colleagues. I hope, Mr. Dlamini, this will contribute significantly in your management plan going forward in this case, and we are hoping to get your feedback possibly in our next session, if ever we've been able to meet the client and discuss on the issue suggested today. One was to help the client realign life goals and find value, accept the cattle. So I think that one also will help the patient to do that, and also the counseling, which will include the patient and also do counseling of the involved stakeholders. And then there was also another one that maybe find something that can distract the patient from overthinking on the issue. That will also be very good. One was suggested was entrepreneurship or smaller businesses. There are many distractions. Some of the things that can do is to find out what exactly this man likes to do, accept the condition. I think sometimes having discussions outside the condition will help him identify really his strengths he can concentrate on, and then that one will help much in going forward, because continually pursuing the issue will continually temper with stress levels, raising hypertension, another stroke again. So we are avoiding that to happen. Thank you so much, team. So today we're learning about arthritis management, and then we also had a case with social issues, and especially with CVA, with contractors unable to do things for himself, polygamy missed, yes. So we have learned today that sometimes helping patients to align the goals can help. We are hoping to hear from Mr. Dlamini with evidence after you have met the patient. So our next session will be on the 2nd of August 2023 at 1 p.m. And we will be looking at now close again to chronic back and neck pain management. And these types of painting is most common with cancer patients. So we'll be looking around chronic back pain and neck pain, especially back pain with prostate and cervical cancer. These patients, they complain about most with this patient pain. So that's why we will also, as a team, look closer to it. How best can we manage chronic back and neck pain in our next session? And then also, team, we request that you click on the feedback link shared with you now before you leave the session, so that you can share with us your feedback concerning today's session and how we can improve for next presentation. And may we request that if you have got time and you have enough data, go to our previous sessions since January last year, learn about those sessions. By the end of this page in November, we will then release a post-test. And then once you have completed that post-test, you will have access to your certificate on pain management from this session. So also in our IECO platform, we have uploaded almost all the materials on pain management. And we hope if you have been registered with us, you will be able to access those materials. Even today's session presentation and material and case presentation will be available for all participants who are registered in our platform. So if you are registered, go to IECO, use your account there, you will be able to join. I wanted to show you how you will see the platform. So this is the platform when you are there. You will see this is the platform that will appear on you. So once you are registered, you will have access to this platform. So you will be able to reach here. Once you are here, when you come to content, you will be able to access all previous session material here. You will be able to access them. They are here. All of them, they are here. You will just choose one that you like. Even today's session will be uploaded here. So once you are here, you come in like you are joining a session, then you come. Or you can just come to the scheduled area and then you look at the content for that session. So all session and previous session that we have covered under pain, they are also here. They are completed. You can also access them. So you can read. And we have also in some of the sessions, we've uploaded even national palliative care guidelines. You can access them and also they are here. But also even the YouTube videos, if you want a specific YouTube, you can go to our Eswatini Hospice at Home YouTube and then access those previous sessions. That's what I can say. And thank you so much, colleagues. May God bless you and meet you on the 2nd of August. Invite others so we can impact many with palliative care. Thank you. I'm seeing a hand. Ms. Zinhle, are you raising your hand? You can share, Zinhle.
No, not really. I was just appreciating.
Oh, thank you. Welcome, Zinhle. See you next time, guys. Thank you.
Bye.
Thank you so much. Bye.
Bye, team.
Thank you, Matthew.